think that where we can have a bigger impact in our patients' lives is if we spent a little bit less time focusing on improving our treatment techniques for that nth degree of improvement with the minutia, right? I think we should be great at treatment, but at some point the gains start diminishing, right? As far as getting education and treatment. But I think where we need to improve ourselves and where we have an area for great and dramatic improvement that will really impact our patients is from a patient management and ownership standpoint. So if I'm seeing a patient and if I'm going to refer them for imaging, let's say, I'm not just going to send them to the PCP and that's it. And that's what a lot of PTs out there are doing. Like if I'm in a system where I can't refer them directly for imaging, that's okay. I'm going to send them I'm going to contact the PCP. I'm going to tell them exactly what I want. I want radiographs. And here's why I want radiographs. And here are the views I want. This is a patient with a pivot and twist injury. So I want an AP lateral and tunnel view of the knee. And the reason I want the tunnel view is I want to be able to look at the intercondylar eminence to make sure that there isn't an avulsion there, which would completely change the treatment compared to an ACL tear. And then once I get the approval, I'm going to schedule a follow-up with that patient that we can review the imaging and continue care. So it's not I'm going to tap in the PCP like we're doing a tag team and then I'm outside the ropes and I'm out. No, we're still in it. We still own that patient, right? Yeah. Now, once the MRI comes back and says it's an ACL tear, okay, then maybe I schedule them, maybe I refer them to orthopedics, whether it's through PCP or not, they're going to go see orthopedics, but maybe in the interim, I can work on some, quad strengthening. Maybe I can work on reducing the edema in the knee or the effusion. There are other things I can do until ultimately a decision is made that the patient wants surgery, right? Because maybe the patient will decide they don't want surgery. Right. Maybe that's their choice. Mm-hmm. But once I discharge them and once I pass them off and once I no longer have them, once I'm not owning this patient, now they're lost in the system, right? So now they choose no surgery, but they don't have any other physical therapy appointments. And now they just get lost in the system. Maybe they go home and get nothing, right? So I think that we need to take on more of an ownership standpoint as PTs. And I think that taking that and improving our management will have a greater impact on our patients than just doing one more therapeutic improvement continuing education course.
I always like to think,
I look at, there was one of the first studies I did, it was on a patient with an Achilles rupture. So it was done with John Tonarelli. He was a clinician, or still is a clinician in the Air Force, great researcher. And anyway, the patient had an Achilles rupture. And what I might see in a lot of civilian clinics is you identify the rupture, you refer to PCP, and that's it. And you never hear from the patient again. You never see the patient again. Now, again, we have a little bit of a scope difference in the military, but a lot of this can be done still in the civilian sector. We ordered the image. Again, you can do it in the civilian sector with the PCP. And then immediately after they got the x-ray, we had them come in and see us. And we did essentially a wet read where we looked at it and made sure, is there anything crazy? Like, are we seeing whatever else? The wet read we got from the radiologist was an Achilles rupture. So we were able to see that on the radiograph. Now, we already know it's an Achilles rupture. We knew that in clinic. Now we have the radiograph, which is the appropriate first step per the American College of Radiology for this. Now the radiograph has confirmed Achilles rupture, but they're still not going to cut this patient until the MRI shows where everything is. Where is the tendon? How much of it is torn, right? So now we need to, before we send them to orthopedics, now we want to get them the MRI. Because the deal is if they go to orthopedics and they don't have the MRI, the orthopedic surgeon's going to say, thanks for coming, go get the MRI, right?
Exactly,
and that's another visit that clogs up the health system. And on top of it, that's another visit, the patient has a copay. So I get the patient, we do a wet read. It's still under their initial visit when they came in to see me earlier in the day. So there's no additional copay. At that point, I contact the radiologist and I say, hey, we have a patient with a confirmed Achilles rupture on x-ray. it's going to be important to get these patients in sooner than later for surgery before this scars down. So I know you guys are booked out for 3 weeks on MRI, but is there any chance we can get them in this week, right? So you use a little bit of political capital. The radiologist will say, hey, yeah, sure, get them in on Thursday. Okay, and that's what we did. So we got them in on whatever day it was. And then right after that call, I call up orthopedics and I said, hey, I have a patient here with an Achilles rupture. They have an MRI on Thursday. Can you see them on Friday? And at that point, once they show up to orthopedics, they're already going to have the x-ray, they're already going to have the MRI, they're going to show up to orthopedics, and then all orthopedics has to do at that point is determine, in conjunction with the patient, whether or not to cut, right? Yep. So we are essentially giving the case on a platter to orthopedics, and then all orthopedics has to decide is whether or not to cut, right? So in orthopedics, they call that the cut to consult ratio. The more times you do surgery as compared to the non-surgical treatments, the better the clinic will operate, right? So if we are able to present cases like that to physical therapy, to orthopedics, their cut to consult ratio is going to be better. But on top of that, that means that we get to keep the patients that are not surgical. But the second we just tap out and tap the PCP and step out of the system, that hurts our patients.